Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Vive Healthcare.
Hello, welcome to the second session in tackling complex HIV cases. Particularly, we're going to be talking about drug-drug interactions with long-acting injectables in HIV care for both treatment and prevention today. My name is Josh Havens. I'm a pharmacist at the Specialty Care Center and also an associate clinical professor at the College of Pharmacy at the University of Nebraska Medical Center here in Omaha, Nebraska. And I'm joined by Dr. Colleen Kelly, professor of medicine, co-director of Emory CFAR, associate dean of research at Emory University from Atlanta, Georgia. In this program, we'll be discussing the following. So we're going to talk about two interesting cases that kind of tackle polypharmacy challenges that have DDIs roped into it with long-acting injectables, both for treatment and for PrEP. We're going to briefly talk about those beforehand, but then also explore some of the tools that we have to manage DDIs for folks, not only on long-acting injectables, but just any antiretroviral, and some of the strategies to proactively, mitigate some of these DDI potential over time. So just to start with a recap from our first webinar, most DDI interactions with long-acting injectables, it's important to know that they are generally manageable, particularly if we know about them, but they're different. And so for cabotegravir and rilpivirine specifically, they are unidirectional. So we are worried about what other concomitant medications may do to the systemic exposure to cabotegravir and rilpivirine. And specifically, cabotegravir is a UGT substrate, and rilpivirine is a 3A substrate. So we're looking at those pathways specifically. And then for lenacapavir, it's different in a bidirectional way. And so not only are we worried about what other concomitant medications may do to lenacapavir, we're also worried about what lenacapavir might do systemically to other medications. So lenacapavir is a 3A substrate, and it's also a 3A inhibitor. So we have to be cognizant of those pharmacokinetic parameters. And probably most importantly, we need to think about how long could these DDIs potentially last because of these the long-acting nature of long-acting injectables. And that potential could last up to 9 to 12 months, maybe a little bit longer after the last long-acting injectable dose. So that's important to think about. What you'll see here is an overview of the pharmacokinetics of long-acting injectables. We have cabotegravir, rilpivirine, and lenacapavir. Showing in the third row here, you'll see the metabolism pathways for each drug in particular. And then the last row is the elimination half-life for both the oral and the injectable versions of each medication. Most importantly, we should note that because of these long-acting formulations, they have flip-flop kinetics, which means that the absorption rate is slower than the elimination rate, and so that the drug stays in the body a lot longer, and that gives us much higher plasma concentrations over time. The DDIs for each of these is really different based on whether we're talking about oral or long-acting injectables. For the oral pathways, we might be more worried about medications that would be affected by cation combinations with oral antiretrovirals. So think about integrase strand transfer inhibitors in particular. And then for rilpivirine orally, we're worried about maybe acid suppression agents, so PPIs and H2 blockers. Those can impact the absorption orally. So particularly for long-acting injectable, we need to think about that if we're using the oral lead-in. But with long-acting injectable treatment, that's a little bit different because we're bypassing the gut. And so you don't necessarily have to worry about those specific absorption-related DDIs. So for cabotegravir, it's a UGT substrate, as we've already mentioned here. We're worried about what other medications might induce those pathways or lower the concentration of cabotegravir. Similarly, with rilpivirine, it's a 3A substrate. So again, we're worried about what other medications might do to the concentrations of rilpivirine. And so specifically, we're worried about medications that will induce CYP3A. And secondly, with rilpivirine, we need to be cognizant of the risk of contributory QTc prolongation with other medications that might have the same potential. Rilpivirine has some sparse data on that, but particularly when it was dosed at higher levels than it currently is now. Lenacapavir, of course, is bidirectional, and so we have to worry about both what other medications might do to specifically the 3A pathway because it's a substrate there. But then also lenacapavir can inhibit 3A, and so we have to be cognizant about what toxicity we might be worried about if lenacapavir was combined with something that was metabolized by CYP3A. So let's get into this case. The first case, I'm going to turn it over to Colleen to present that.
Yeah, thanks, Josh. I think these cases all highlight some of the really important concepts that you just covered. So our first case is Shelley. Shelley's a 36-year-old transgender woman. She is on antiretroviral therapy for HIV treatment and is actually on the combination of cabotegravir and rilpivirine plus lenacapavir, which we are using increasingly in patients with a history of treatment experience and drug resistance to either the cabotegravir or rilpivirine component of that injectable agent and inability to adhere to oral medications. And so because Shelley has had difficulty adhering to oral ART and a history of rilpivirine resistance based on prior genotypes, her clinician elected to use the combination of rilpivirine plus lenacapavir in order to try and overcome some of the difficulties with adherence and pre-existing resistance. Concomitant medications for this patient include estradiol and spironolactone for gender-affirming care, quetiapine for mental health issues, as well as lisinopril for hypertension. We did learn during our clinical conversations that there is some injection drug use, primarily methamphetamine, but given the current situation with illicit drug use in the U.S., there is certainly concern for fentanyl adulteration, and Shelley expressed that concern as well during the clinical visit. So, what drug-drug interactions should we be concerned about? Josh, what stands out to you when you hear about this case and think about drug-drug interactions?
Yeah, I think first off, we with this patient in particular, because she's a heavily treatment experienced patient, we have little room for error, really, if we think about this, because she already has some resistance notable. And really, we don't want lower levels of our long-acting injectables. So number one, from an HIV treatment perspective, we want to make sure that she's receiving durable levels of these antiretrovirals. When I look at the medications, the concomitant medications that might impact the levels of her long-acting injectables, there aren't any that she's on, right? So there's no 3A inducers or any broad inducers that are on board, such as rifampin or some seizure medications, or sometimes we use carbamazepine, oxcarbazepine, medications like that. Those can also be used for bipolar disease, right? So we have to be cognizant of medications that would lower the exposure to the long-acting injectables. But because she's on lenacapavir, we also need to think about, well, we know lenacapavir is a 3A inhibitor, so it can affect other medications too. And in this case, with Shelley, we have the medications that are prescribed to her, but then also the substances that she uses outside of that. And there's a lot more uncertainty with the latter because we don't necessarily know exactly where she's sourcing those substances. But if we just focus on the medications that she's being prescribed, really the one that stands out the most is quetiapine. And quetiapine, it's an antipsychotic class. used for a lot of different reasons for mental health purposes. But it's a 3A substrate and it's very sensitive to 3A. And when we think about it in the HIV space, boosted protease inhibitors, we know that when they're combined with quetiapine, you get a 6-fold increase in exposure to quetiapine, which if we started somebody out at a intermediate dose with that would be a problem because they'd get 6 times what we thought they were getting. Now, lenacapavir is a moderate inhibitor, and it's really hard to judge how much additional exposure to quetiapine somebody may get from that. But my guess is that Shelley has already been titrated up to the stable dose while she's already on these long-acting injectables. So I'm not necessarily worried about what to do clinically with Shelley, with quetiapine in particular, because I'm just going to manage that based on response right now, because I'm assuming we're not going to change the antiretrovirals. But if she were ever to come off of long-acting injectables, then we would have to think more about what do we need to do to the quetiapine dose in the case where she maybe switched to a different oral antiretroviral regimen. Now, with the non-prescribed substances that she's using outside of that, methamphetamine, it's also metabolized by 3A, but in a minor way. And so we can expect lower effects from that. Even though lenacapavir is on board, we wouldn't expect generally toxic levels of methamphetamine due to that interaction. But importantly, we do know that there is some concern about cutting in opiates with methamphetamines on the street, and that presents interesting challenges because depending on how much or what type of opiate is cut in, that can be a big problem and a risk for overdose, particularly in this case because lenacapavir is an inhibitor. So if we think about fentanyl, for example, it's a 3A substrate, and it has a very narrow therapeutic window, meaning that little differences in dosing or changes in systemic concentrations could have big effects in terms of toxicity. And that's really the biggest concern here is we don't want that to be there. Lenacapavir also on board, and then Shelley would overdose. That would be a very bad situation, right? So I think really the biggest piece with this case is patient counseling, right? And just making sure that the patient knows about that. So I'm curious, Colleen, what do you think about, like, how would you address this with Shelley if you saw her in clinic? What would you talk to her about?
Yeah, I mean, I think that, knowledge and awareness is where you first start. Obviously, every engagement has to be around shared decision making. Adherence to the ART and viral suppression and maintaining that is going to be, obviously super important for Shelley, and I'm sure that she agrees. So I do think we can have a very frank discussion about the potential for interactions with opiates. I want to say potential because my understanding is there's not that much clinical experience yet to know how much these drugs actually do interact, and that some of the concerns about overdose potential, while certainly possible, are theoretic at this point in time. But I do think we can talk about those things. We can talk about having naloxone on hand for prevention of overdose. We can talk about substance use treatment if interested, and test strips for narcotics or for opiates. Lots of different things that we can consider to help keep Shelley safe as much as we possibly can. And so I think that those are the things that I would review. And thank goodness for pharmacists. I say that on almost a daily basis, because lots of people don't have access to an expert pharmacist, and you're left to kind of to identify and look up these interactions on your own. And so this is when a great case where I pull out Liverpool. And one thing that we didn't discuss is any interactions with gender affirming hormone therapy. And if you do a quick search, you'll realize that there are no known interactions with gender affirming hormone therapy, and that is also a high priority for transgender people to maintain those gender affirming hormone concentrations. And so that's another conversation that we would have and reassure that we don't expect to see any effect either on the hormones or on the HIV medications due to drug-drug interactions. And so that can be very reassuring for people. So again, I think it's about ongoing discussions, shared decision-making, awareness, and monitoring closely for the potential for any drug-drug interactions in someone who is on the regimen that we reviewed, using gender-affirming hormones, using substances that may interact. But I think eventually you will get some comfort with understanding that many of these can be managed given the patient's preferences and desire to keep them on their HIV therapy for the long term.
Yeah, I'd also add, Colleen, I think documenting the DDI potential really well in the chart is really important because, we would assume here that Shelley might have other providers that may not be in tune with DDIs or the potential from our antiretroviral therapy that we're giving her. And I think that while not all providers look at it, at least it's there, right? And if they see it, they'll know, hey, we should be worried about this. And the provider class in particular that I worry about the most probably is the psychiatrists, right? Because sometimes those are the medications that get added on just kind of after the fact sometimes, and we just they can have interactions, particularly with lenacapavir. Let's move on to the second case, Colleen.
Yes, thank you. So the second case is Dana, a cisgender woman who's 28 years old. This is a social worker who is currently living in Wyandotte County, Kansas. And this is important because we have heard of a tuberculosis outbreak in that particular area. So this patient is on pre-exposure prophylaxis on long-acting cabotegravir for HIV prevention since 2023. Unfortunately, she was exposed and diagnosed with TB in December of 2024, and this is an active pulmonary TB case. So Dana was started on rifampin, isoniazid, PZA, and ethambutol. Because of potential for or a known drug-drug interaction with the rifamycins, the clinician switched Dana to oral TDF-FTC during TB treatment to maintain HIV pre-exposure prophylaxis. So in this case, we have already identified one well-known drug-drug interaction. So any additional thoughts about cabotegravir and the rifamycin and the potential to restart in the future, et cetera?
Yeah, I think this is a really important case, right? Because if this DDI wasn't recognized and say this patient continued on cabotegravir for PrEP, that we're risking lower levels of cabotegravir, and if she was exposed to HIV at any time point, and seroconverted, that would be a big problem. So it's good to see in this case that she was changed to an oral agent that was there. In terms of when can, after her ripe treatment for TB, when can she restart cabotegravir if she chooses to go back on? That it's a little muddy, but with enzyme induction, like what rifampin will do, those effects will last even after rifampin is stopped taken. So sometimes those induction effects can last for 2 to 4 weeks afterwards. So what I would generally recommend is to continue, in this case, oral PrEP for at least a month after she's done with rifampin, and that way we're not risking any lower cabotegravir levels, particularly when she's getting loaded back up at the beginning. And then secondly, we have to think about, in terms of pregnancy too with this. We already know that, generally speaking, with a lot of antiretrovirals, as women progress through trimesters, when we get to the latter stages, the blood volume expands. And so the concentration of drugs can be lower just because of the expansion of blood volume. And so if we added another drug interaction on top of that, you'd get lower levels too. And that would, again, be a risk for problems if she was exposed to HIV. And I think it's important to recognize, in this case, because she's a woman, we wouldn't necessarily probably use intracytamine tenofovir alafenamide. But if we did choose that, there's important DDI considerations that we need to think about with rifampin with the tenofovir salt itself. And so we do know that TAF, or tenofovir alafenamide, is metabolized by PGP partially. So that's P-glycoprotein. It's the drug exporter protein. And rifampin will induce that. And so you can expect lower levels of TAF in those cases, and that would be a problem too. So we know that tenofovir disoproxyl fumarate, so TDF, is not affected in that same way. And so in this case, she was put on the correct oral PrEP, regimen, both from her population standpoint, but also from a DDI risk perspective. And that's good to see. What other things do you think about with this, Colleen? Do you have any other perspectives on how we should manage her?
Yeah, I mean, I think this is a somewhat of an unfortunate drug-drug interaction, that is manageable, but to not forget that, oral adherence to daily FTDF is difficult for a lot of people, and that it is, shown to be inferior to injectable cabotegravir with respect to HIV prevention. So I think there's got to be a lot of conversations with the patient around issues and maintaining adherence. Potentially she's on some sort of observed therapy for TB. We could maybe potentially consider slipping in the TDF FTC within that directly observed therapy if she was receiving that. But I really think I would worry more about poor adherence, or less adherence at least, to the TDF FTC, given what we know about the superiority of injectable cabotegravir based on adherence for prevention of HIV. So I think I'm worried about HIV acquisition from a DDI perspective, from an adherence perspective. And so I do want to, I think, have some really open conversations. I want to keep close follow-up and close conversation with the patient about these issues to ensure we have the best outcome possible for both the TB and maintaining HIV prevention efficacy as well.
Thanks, Colleen. Yeah, I think really in this case, the one thing I didn't mention earlier, particularly with TAF and TDF, whether we use TAF in a cisgender woman or not is still up for debate, I think. But the DDI potential is really between the plasma and the intracellular concentrations. And not to get too far into the weeds, with TDF, it's a lot better in that scenario. So just to wrap this up here, cases with long-acting injectables with DDI potential are really interesting. And I think there's still a lot that we have to learn about. I want to reiterate that most of the DDIs are manageable, particularly if we know about them. It's important to recognize that sometimes in certain electronic health records, when you give an injectable medicine, some of the DDI checkers are not built into that. And so that's also something that we should take into consideration, which is nice, again, as Colleen stated earlier, to have a pharmacist on board because we're so comfortable with that stuff. But that's not always the case, and just have a trusty resource, that you can call, if even if it's not within your own institution. But we also have good resources then with the DHHS guidelines, DDI checker, but also Liverpool's checker as well. And just to highlight the interactions, particularly with cabotegravir and rilpivirine, those are unidirectional. We're worried about what other medicines might do to the exposures of those medications. And with lenacapavir, it's bidirectional, so we want to make sure that we're considering both what other medicines might do to lenacapavir, but also what lenacapavir might do to other medicines in terms of systemic exposures. And with that, I want to thank you all for attending this second session or second webinar on tackling complex cases with long-acting injectables and DDI potential.